live from Miami Beach. This is Dr. John Bennett broadcasting for Neurosurgical TV. We have another episode of Daily Dose of Neurosurgery Education. And today we have the honor of having Dr. Vijay from Hyderabad. He's going to introduce himself and tell about himself and go into his presentation. Welcome, Vijay, and it's all yours. And thank you for coming.
Thank you, sir. Thank you. Good afternoon, my dear friends.
Okay,
today I will be discussing the most important topic of neurosurgery, especially spine surgery, that is upper cervical spine injuries. I am Professor M. Vijay Sarathi, working in the Nizam Institute of Medical Sciences. I was ex-colleague of Dr. Manas. So, to begin with the spinal instability, basically we have two theories. One is Holdsworth, who has divided the spinal column into two columns. One is anterior and posterior. And Dennis has classified into three columns: anterior, middle, and posterior. And we know that White and Punjabi has defined the stability and instability as the ability of the spine and the normal physiological loads to limit the patterns of displacement so as not to damage or irritate. That means spine and the normal physiological load should not create any pain or deformity or deficit. So what is so special about upper cervical spine? Injuries are not uncommon, that is, they're common injuries, but they are difficult to recognize by the fact that the CV junction area is covered anteriorly by the facial skeleton, laterally by the mastoids. If they are not recognized, they lead to disastrous consequences, and we have various treatment modalities to treat these spinal fractures. Coming to the symptoms of upper cervical spine trauma, you have classical 3Ds, that is deficit, deformity, and dolor, that is a pain. And the signs which are specific to the upper cervical spine trauma are lower cranial nerve palsies, dysphagia, probably because of lower cranial nerve palsies or prevertebral hematoma, some special sign of C2 neuralgia, or maybe called a symptom. And sometimes patients may present with a posterior circulation stroke because of the vertebral artery dissection. So there are some consensus guidelines how you measure the measurements in the CV junction trauma. For example, suppose if you look at the occipital condyle fractures in the sagittal plane, this is how you draw the pattern of the measure of displacement from the base of the occipital condyle to the tip. That means this is the gap where there's a displacement of the fracture. And this is measured in terms of apposition, percentage of bone which is in contact with its parent bone. Same thing is true in the coronal plane, where you measure the displacement as well as opposition. This is how the measurements are drawn in the occipital condylar fractures. Coming to the measurements of the CV junction, you have measurements. The basion dense interval, you draw a point from the basion, tip of the adenoid, you draw a line, and also there is a basion axis interval. You draw a line from the posterior surface of the axis, and you draw a line from the tip of the fibers. This is also measured. This is how you measure the various measurements of the CV junction, especially in case of trauma. Other most important the measurement is the odds ratio, where from the basion you draw a line to the posterior artery of the atlas and opistheon to the tip of the dens. Other one is the lateral mass displacement. This particular measurement is especially useful in treating the Jefferson fractures, where you look at the lateral mass displacement, the displacement of the C1 lateral mass over the C2 lateral mass. For example, if this is X and if this is Y, X plus Y is more than 6.9 millimeters, that indicates probably that transverse ligament is torn, where the indication of surgery lights. So when there's a displacement more than
Excuse me, VJ. We're going to have to stop here because we're going to have to figure out, try to improve the sound because your sound is breaking up. You have a smartphone with you?
Yeah.
Okay, if you can, we can try entering the webcast with the smartphone just for the voice. In other words, turn your voice off on your desktop or laptop there and turn your voice on your smartphone on so we get your audio from your smartphone. Do you know what I'm saying?
Yeah, I got it. Is it okay now?
Yeah, now it's good. Is it? Yeah, it's good.
I'll continue like this.
Yeah, it's good. Okay.
Let me try this one.
Okay, carry on.
Sure. So another measurement in terms of hangman fractures is a translation between the C2 and C3. You draw a line from the posterior border of the C3 and C2 and measure this distance. If this is more than 3.5 millimeter, it is supposed to be unstable. That means the ligaments are no longer in a capacity to hold it stable. Same thing is true with the C2-3 angulation, where you draw a line from the inferior part of the end plates and try to measure the angulation. If the angle is more than 11 degrees, that means ligaments have failed. They're no longer in a capacity to hold the spine stable. This is how you measure the displacement patterns in the odontoid fracture. You draw a line from the anterior part of the C2 body as well as the anterior part of the broken odontoid. You look at the displacement in terms of millimeters, and same thing is holds good with the angulation. All these things are very important in deciding the surgical therapy, whether you want to go anteriorly or posteriorly or whatever it may be. So coming to the occipito-atlantal fractures, these are very, very important. If you look at the joint of occipito-atlantal joint, this is very deep in the neck and very large force is required to destabilize this joint. For example, look at the occipital condyle, which is very robust structure. It is convex anterior-posteriorly and also from the side to side is a very big chunk of the bone which exactly fits into the C1 lateral mass. Look at the superior articular facet of the C1, which exactly is a key of the occipital condyle. So they exactly fit into each other. It's very large force is required to destabilize this joint. So the occipital condyle fractures are divided into three categories. Type 1, which are called as a burst fractures. Look at that, the entire occipital condyle has become into pieces. And type 2 is a fracture where the fracture line from the skull base extends to the occipital bone and gives rise to fracture here. This is type 2. And type 3 fracture is a fracture where the occipital condyle has got dislodged from the parent bone. This is where our surgical decision will come into picture. So rest 2, type 1 and type 2 are benign fractures which can be managed conservatively. So how do you treat these OC fractures, occipito-cervical fractures? What you need to ascertain is there any dissociation between the occipito-cervical joint or not? If the dissociation, occipito-cervical dissociation has resulted out of the fracture, you need to perform the occipito-cervical fusion. If dissociation is absent, that means the occiput and cervical is still together. You can make the patient to wear hard cervical collar for 6 weeks and reassess him after 6 weeks. If he is doing well, all his symptoms of instability has come down, you can manage him conservatively. So how do you really account for the occipito-cervical dissociation? So basically there are 3 types of occipito-cervical dissociations. One is type 1, when the occipital condyle moves forwards, that is anteriorly in relation with the odontoid process or the C1 lateral mass, or type 2 when it has migrated superiorly, that is when the apical ligament is torn, it is something like distraction injury, and type 3 when the occipital condyle has moved posteriorly. So all these 3 patterns of occipito-cervical dissociations are possible in this particular area, And it is very pertinent on our part to identify these dislocations before we treat these patients. So this is what it looks. If you look at this, this is the occipital condyle and this is the C1 lateral mass. Both of them have got dissociated with each other. So the minimum gap, that is beyond 1 millimeter gap between these two, is supposed to be abnormal. Same way, this is if you measure the Harris measurement, that is a dense basion dense interval. If it is more than 12 millimeters, it indicates that probably there is a apical ligament injury. Same thing if the basial axis interval, if it is also more than 12 millimeters, that is there is a loss in the cranio-cervical relations, and you should suspect the occipito-cervical dissociation. Same thing is true with the Powers ratio, where the basion, a line drawn from the basion to the posterior arch of atlas, and a line drawn from the opistheon to the tip of the dens. Normally, there the ratio is 1. If it is more than 1 or less than 0.8, that indicates that there is a imminent or existing occipito-cervical dissociation, which mandates occipito-cervical fusion. So Lendl has classified the Atlantic fractures into type 1, type 2, and type 3. Type 1 are those fractures where the fractures are either anterior or posterior to the lateral masses. Usually they are called plow fractures. They are stable fractures usually. And type 2 fractures are fractures there where the fractures will be lying both anteriorly and posteriorly to the lateral masses. This is typical of a Jefferson fracture. Here you find a fracture line anteriorly and posteriorly on one side. Here is a fracture line anteriorly and posteriorly on the diagonal sides. And third type of fractures is that a comminuted fractures of the C1 lateral mass. And fourth one is the linear fractures of the C1 lateral mass. So this type 3 can be managed conservatively. And what we need to look at the type 2 fractures where they may require the surgical intervention. So coming to transverse atlantal ligament, the class Dickman, Curtis Dickman from Barrow Neurological Institute has classified these fractures. The transverse atlantal ligamental injuries are type 1 or type 2. Type 1 injuries is the injury. The transverse atlantal ligament has been cut either at the center or at the periphery. In both these circumstances, when there is a complete loss of integrity of transverse atlantal ligament, surgery is the only answer. If the transverse atlantal ligament is because of the bony avulsion, in these cases the halo or conservative treatment may improve, maybe become successful. So when you look at this Jefferson fracture, where there is a C1 lateral mass and which is getting apart, that means that this is where you need to measure the lateral mass displacement. This is if this and this, if you add this, if it is more than 6.9, that is most likely the transverse atlantal ligament is torn. When you look at this, you can find that the occipital condyles are descending down. That means that there is some amount of cranial settling happening because of the Jefferson fractures. When you take the atlas, these red lines indicate that these are the fracture lines of the Jefferson fractures. This orange line indicates fractures of the lateral masses. This green line indicates the transverse atlantal ligament injury. This blue line indicates the transverse atlantal injury because of the bony avulsion. So Jefferson fractures were almost described almost 100 years ago by G. Jefferson. He published his case series of 4 cases, autopsy studies in British Journal of Surgery in 1970. He could conclude that these fractures are resulting from the axial compression and there is severe dislodgement of the lateral masses in all these cases. And also he could demonstrate that the transverse atlantal ligament in these patients were badly torn. So in this, again, this case, this is the lateral mass displacement. This plus this is around 6.9, which indicates the transverse atlantal ligament is torn. I'm repeating repeatedly because is a very important point to advocate surgery for these patients. Suppose in this case, probably the lateral mass displacement is more than 6.9. The only we look at this when the transverse atlantic ligament is torn, the procedure of choice in these patients would be C1, C2 fusion, irrespective of the fusion method you adopt, with the transarticular screw or C1, C2 screw, whatever may be the translaminar screw, whatever said and done, the treatment of choice when there is a transverse atlantic ligament.
Excuse me, Vijay, we're breaking up again. Is there anything you're doing different? We're breaking up a lot again. Okay, so just make adjustments, okay? Let's try again. Keep going, just adjust.
Yeah, is it okay now, sir?
Yes, it's okay now.
Yeah, if the transverse atlantal ligament is broken, the treatment of choice would be C1, C2 fixation, irrespective of the fixation method. So coming to this aspect of the Jefferson fracture, where the lateral mass displacement is not less than 6.9 and the transverse atlantal ligament is not torn. In those situations, probably people still perform the C1 lateral screws with a connector, and they tend to compress both the screws so that these two fragments come and oppose to each other, so that there will be a fusion. This is what the X-ray looks like after both the transverse, the C1 lateral mass are brought together. So coming to rule of Spence, there is a recent article by Wood et al. In 2018 Neurosurgery. They say that it is not 6.9, so-called the rule of Spence is not an absolute number. Sometimes you may find the transverse atlantal ligament broken when there is a lateral mass displacement is less than 6.9, even at the range of 3.2 millimeters. That means the transverse atlantal ligament integrity should be confirmed by the MRI scan and in order to decide about the surgery. Coming to the atlas fracture, let us look at the algorithm. Suppose if the atlas fractures are combined with the C2 fractures, the treatment guidelines has to be done as per the C2 fracture. Suppose if there is a disruption of transverse atlantal ligament, and if there is a type 1, the non-bony avulsion, straight away you have to go for C1, C2 fusion. Suppose if it is type 2, bony avulsion, you can try conservative treatment with a halo brace, and again at the end of 3 months you can do a flexion extension X-ray, and if it is unstable you can go for fusion. Coming to this these fractures where transverse atlantal ligament is intact, that means lateral mass displacement is less than 6.9, all these patients can be managed with the cervical collar for 3 months, and again you have to follow them up. Coming to odontoid fractures, they are the most common fractures of the upper cervical spine. Type 2 odontoid fractures are the most common fractures, and if not untreated, there is 100% non-union in these patients because the paucity of the blood supply at the base of the odontoid process where the actual fracture site. The differential diagnosis of the type 2 odontoid fractures is one ossiculum terminale. Morphologically, it is a smaller segment lying at the apex, and second one is the os odontoideum. The features by which you can differentiate os odontoideum from the type 2 odontoid fracture, that you have a clue, that is the anterior arch hypertrophy, that being a congenital in nature, and this particular fragment will be above the interjoint line with C1, C2, and this has a smooth margin contrary to the type 2 odontoid fracture which has a ragged margins. This is how you will differentiate between the os odontoideum and the type 2 odontoid fracture. So how much force is required to fracture a spine? Generally, we think we need lots of force is required to fracture a spine. Here is a case where this patient had a trivial fall and became quadriplegic. When you look at this, entire spine is fused. When he fell down, the force which was generated at the lower spine has come to the upper spine, and it has become many-fold. That is what is called cantilevering effect. that has resulted in the fracture of the C3-4 and he became quadriplegic. Suppose if there is a fusion of this particular spine also, as you find in this case, the only thing left to be fractured is the odontoid process. So odontoid fractures is most common fractures in the patients, elderly patients who are suffering from diffuse idiopathic skeletal hyperostosis, where the most of the spine is fused. Here, the non-halo treatments always fail in the geriatric population. Of course, they cannot tolerate the halo fixation in view of the lung compliance issues, and hence surgery has shown consistently better, that is C1, C2 fixation in all geriatric type 2 odontoid fractures in terms of reducing the morbidity and mortality. So initially, when type 2 odontoid fractures, that anterior odontoid screw, when it was introduced in 1990s, it was very huge welcome for that surgery, with reported rate of 90% fusion rates. But over a period of time, people have observed the obstacles in terms of age, poor bone quality, and a fracture type which is anterior inferior type, and people coming too late to the treatment. So there are certain factors, good factors for the treatment success, that patient should have a healthy bone, there should not be any deformity of the fracture, the subaxial spine should be mobile, patient should be thin, because thick patient, the trajectory of the screw passage will be difficult. So what are the red flags in doing the odontoid screw fixing, that's anterior screw fixation? Suppose if the gap is more than 3 millimeters and lateral translocation, more than 5 degrees of angulation, more than 1 degree of lateral tilt, some en-pass bony cyst, Klippel field anomaly, all these factors will tell us that this patient is not a suitable candidate for the anterior odontoid screw fixation, which is supposed to preserve the rotation in all the cases. So what is the literature for that, literature evidence for the treatment of odontoid fractures? Evidence is poor, and if you miss the injury, there is going to be 100% non-union, and halo, invariably halo treatment fails. And almost the reported non-union rate of almost 15 to 85% in various series. And even with the successful fusion with the anterior odontoid screw, there is 30% reduction in the rotation in the long-term follow-up. So most important criteria in deciding when you are going to perform the anterior odontoid screw is the two most important things. One is the intact transverse atlantal ligament, and second one is the ability of the surgeon to reduce distal fragment in line with the screw passage. This is very, very, very important. In case if these two things are not met, there is no point you can do the anterior screw fixation. So the ideal patient would be a thin patient with a healthy bone, with a fracture type of anterior superior posterior inferior type, undisplaced, unangulated, and fresh and non-deformed axis. So this is how the anterior odontoid, all of you know about this. There's nothing more I can tell about that. So this patient, we performed the odontoid screw, and initial X-ray looked okay, but patient went home and came back with the persisting worsening atlantoaxial dislocation. The screw has broken, that it has cut through the anterior surface of the C2 body. Probably screw trajectory was too superficial, so this has to be revised again. In the CT scan, you see that it has resulted in the C2 fracture. So the patient, again, we had to remove the screw and we had to perform the posterior C1, C3 fixation. So you should be very careful in deciding the screw trajectory. Once we miss the screw trajectory, entire surgery will be big mess. Coming to hangman fractures, very important fractures. So you have type 1, type 2, and type 2A, and type 3. Type 3 are highly unstable. Type 2 is intermediate stable, and type 1 are stable. These can be managed conservatively. So how do you measure how do you estimate the instability in hangman fractures? If you find the displacement more than 3.5 millimeters or the angulation more than 11 degrees, that indicates this particular hangman fracture requires surgical fixation, either anteriorly or posteriorly. Look at this case. This case is a type 3 hangman fracture with a gross subluxation and rotation. When the MRI is taken, you can see that C2-3 subluxation, gross subluxation, and the disc is collapsed. The posterior superior part of the C3 is impinging upon the cord. So here options are: conservative treatment is ruled out, halo treatment yes, but halo may not maintain the reduction after having achieved it, and surgery is only option, either anterior or posterior or a global fixation. So this is what we have performed. We performed a single anterior fixation from C2 to C3, and also we included a C4 to have a long cantilever in order to reduce this fragment. So this will result in the beautiful fusion within 3 months of the entire fractured site as well as the grafted area. This results in very stable fixation at the end of 3 months. So this is what the technique is of reduction of the high-grade spondylolisthesis, the high-grade hangman fractures. This is, we call it as sequential tightening of screws. You place a plate over the C2 and C4, engage the screws, and once you partially engage C2 and C4 and put a screw into C3, with a gradual tightening of the screw, entire C3 can be pulled up. So this is what the intraoperative pictures, and this is at the end of immediate postoperatively, we have this fracture here, and this is a graft here, and at the end of 6 months later, this is a beautiful fusion you can see both at the grafted area as well as the fracture site. So what is the anatomy? Let me just one slide about anatomy of the hangman fracture. The pars fracture is because of the hyperextension, and the distraction and hyperflexion will cause a disc fracture and also dislocation of the fragments. And basically you have two segments. One is a cranioventral. This is the cranioventral segment of the hangman, and the dorsocaudal segment of the hangman. These are two fracture fragments which have to be fused with the surgical manipulation. Normally, the gravity passes through the C1 lateral mass, comes to the C2 lateral mass, goes to the pars and goes down along the facets and comes in front and goes down into the C4. Normally, 80% of the weight is passed through in this way in a normal circumstances. When this fracture happens, with the fusion anteriorly, we are going to place a graft here and we are going to fuse here, so that the entire the gravity is shifted here, and this is put to rest, and this, so that this can heal gradually. So this is a typical case of a type 2A hangman fracture with a minimal subluxation, minimal angulation. There is definitely disc space injury and anterior longitudinal ligament tear. So this requires anterior fixation, C2-3 plating with the C2-3 discectomy and fusion. These are the steps. We put a plate in, put a screws into C2 and C3, and put a graft in between the C2 and C3. So this is another case, high-grade hangman fracture, where there is a severe subluxation, huge gap, huge prolapse of C2 over the C3, and this patient was put on traction. There is almost reduction of the fracture fragment. Now the option in front of us is either to go anteriorly or posteriorly. And after deliberate, so many deliberations, one of us, we wanted to go posteriorly, but once we passed the screw, this was the result. So the fragment has moved forwards instead of coming back. So, what are the red flags to put a screw of the pars? At what circumstances you end up doing like this? So one of the literature surveys says that the permissible gap which is of the fracture, which allows the posterior screw to be passed, is around 2.5 to 3 millimeters. So loss of or tear of anterior longitudinal ligament is also a factor which you should take into consideration, to not to go from back to put a pass through, in order to avoid disastrous consequences. So advantages of anterior approaches are: one, we can address the pathology directly. Here we are only tackling or fusing the C2, C3, where the preserves the C1, C2 rotation. You can very well maintain the lordosis by simple maneuvers like putting a lordotic curve to the plate, and you have a large fusion area between the C2 and C3. So of course, posterior approaches have their own inherent disadvantage of prone position. And if the gap of the parts is more than 3 millimeters, we cannot put the parts through, and you end up doing C1 and C3, which limits the rotation. Of course, our friend vertebral artery is always a hazardous doing in posterior procedures, and extensive muscle dissection is required. And of course, there will be a restriction of rotation. In the previous case, again, we had to remove the hardware, and we went anteriorly and fused from the C2 to C4. And this is the result of in the postoperative MRI, shows a beautiful realignment of the cervical spine with the surgery. So halo complications are pin related. A lot of issues in the chest expansion, especially in countries like India where temperature is high. Many people refuse to wear the halo fixation. So in these halo fixation in the highly unstable fractures, the non-fusion rates are ranging from 20 to 70%. So halo is a very limited role in the in patients where the established instability is there in the CV junction area. Coming to C2 fractures, these fractures are non-odontoid, non-hangman fractures, which comprise of 20% of all cervical spine fractures and around 1/10 of upper cervical spine injuries. All of us know that C2 body is the region which is lying below the odontoid process in between the two parts interlaterals on both sides. So here is a 32-year-old male patient who presented with a road traffic accident followed by pain and restriction of neck movements. He has no neurological deficits. This is a fracture. This is neither hangman nor odontoid type 3. So in the axial section, you find the sagittal split of the C2 body. These patients generally going for surgery is the better option because they can go back to the work very early. So in this case, the treatment options are conservative, halo. As I said, halo has its own inherent problems. Surgery is an anterior or posterior. So in 1933, Starr et al. Reported 6 atypical hangman fractures. They named them as the atypical hangman fractures, which were actually supposed to be the fractures of the axis body. So Benzel again, he classified these axis fractures into 3 varieties. One is coronal fracture, sagittal, horizontal. Let me take you to this picture. This is type 1. There is a fracture line in the coronal plane, which splits the body into 2 coronal halves, one half in front, one half in the back. The half is there in the front, it can come forward. This is type 3, which is almost similar to the type 3 odontoid. This is type 2 Benzel fracture, which splits the axis into 2 equal halves. Hello?
Yes, the sound is breaking up pretty significantly. Yeah, could you just move or do whatever?
Yeah, just give me some time.
Yeah, okay. No, everybody realizes the challenges. Ready to start again?
Yeah. So Fujimura has classified these fractures into 4 types. One is avulsion fractures and horizontal fractures and burst fractures and sagittal fracture in order to classify them into 4 groups. Coming to the literature of the C2 fractures, we have very sparse literature, and suggested treatments are many. Many people suggested non-operative treatment as a primary therapy for the C2 fractures in all majority of previous studies, and there is no class 1 evidence for the management of C2 body fractures. So certain cases, definitely these fractures require the surgical management. So the consensus regarding the surgical indications in these fractures are fractures which are associated with the instability of adjacent joints, and unstable type 1 benzal fracture where the large fragment in front comes forwards, and the fractures which results in the spinal cord compression, and if there is a fracture which goes and disrupts the superior articular facet of the C2. All these fractures, they require surgical stabilization. So this is typical case of type 2 sagittal split, which patient, we advise the patient to have a halo, because this is supposed to have this. When you look at the MRI, there is a lot of ligamental injury. So patient wanted surgery. So this patient was treated with the posterior C1, C3 fixation. This is another type 2 benzal fracture where there's a combination of the C2 vertebral body, and this patient basically also was treated with the posterior C1, C3 fixation because we cannot put screw into the fractured vertebral body. This is another case of benzal type 1 where there is a sagittal fracture here where the C2 body has fractured and had a propulsed in front, and this is also supposed to be unstable fracture where this fracture was treated with the anterior cervical fixation from C2 to C3. Another comminuted fracture of C2 where you can see the body fragments of C2. This patient doesn't really, conserving this sort of patients is hazardous because of a large amount of comminuted fracture. So this patient has a long neck. We performed the anterior C1 to C3 fixation with a screw part into the last segment of the bone in order to keep it in alignment with the rest of the spine. Benzal type 1 fracture, this is benzal type 1 fracture, where there is a large fragment in front getting coming out of the C3 body, and this patient as well had a transverse atlantal ligament injury. That means it required C1 C2 fusion. So this patient underwent C2-3 anteriorly in order to give a blood first to this particular C2 large fragment, and followed by C1 C2 fixation. Another neglected C2 fracture where patient has come to us very late, and patient had neurological deficits. This patient, we put him on traction. Once there is a reasonable reduction, we had to perform C2 carpectomy, put a cage, and did a C1 to C4 anterior fixation. We had to use a larger cantilever because this was is a highly unstable fracture. So C2 fractures, what is the best method of treatment? Still, it is under debate. Management of C2 body fractures should be individualized, and many of them can be managed conservatively. However, with the recent advancing in the imaging where you can look at each and every corner of C1, C2 complex, the surgical indications are becoming more and more. So to summarize, the summary of surgical decisions are like this. Suppose if there is an occipito-cervical dissociation, you look occipito-cervical fractures, you look at the dissociation between the cranio-cervical dissociation. If dissociation is present, they are the candidates for the surgical fixation, that is occipito-cervical fusion. In the C1 fractures, the most important concern is the transverse atlantal ligamental integrity. If transverse atlantal ligamental integrity is present, you can conserve them. If transverse atlantal ligament is torn, the C1, C2 fixation has to be performed. Coming to odontoid fractures, the only indication for the anterior surgery is a presence of transverse atlantal ligament in normal transverse atlantal ligament. In case transverse atlantal ligament is torn, the management should be C1, C2 fixation, posterior C1, C2 fixation. Coming to hangman fractures, most of these fractures can be managed by anterior surgery. It has more direct exposure to the fracture site. This can be debrided thoroughly. A large fusion area for the graft can be kept there. So most of the patient, there's no blood loss, no muscle dissection. So C2 fractures have to be individualized. So these are the, and if there is a combined fracture of C1, C2, all these fractures have to be managed as per the guidelines of the C2 fracture. So these are my summary of my talk, that is right ranging from the occipito-cervical fractures to the C2 fractures and combined fractures.
Okay, thank you very much. Okay, Manas, are you there? Manas, are you there? Or perhaps he isn't. Okay, let me get you off screen share there. And we'll open it up for comments or questions. Okay. Well, there's Manas. Hi. Okay, why don't you introduce yourself, Manas, and take over, please.
I'm Manas Panigrahi. I work as a neurosurgeon at Hyderabad, India, and thank you, Dr. Vijay, for giving a clear concept of how to manage trauma of the upper cervical spine. I see Dr. Atul Goyal online. I'll request Professor Atul Goyal to give some comments. There is one question from Dr. Raghuram. He has asked, is there a role of surgery for type 2B odontoid fractures?
Type 2B odontoid fractures, the indications remain the same. Presence of transverse atlantal ligament should be normal, and the fracture fragment has to be in alignment with the axis. The major problem with the type 2 is the inability of the surgeon to engage the distal fragment. Most of the time you end up doing C1, C2 posteriorly. Hello?
Yes.
Yeah, thank you. Thank you. There's another question, that what is a protocol to follow in cases of upper cervical spine injuries associated with cord edema?
So if there is a cord injury, that means all fractures are unstable. The moment you find upper cervical spine injury in the CT scan or MRI, immediately they have to be put on cervical traction, and based on the available guidelines, the treatment option should be offered. Most of the patients where cord injury is there, most of them are almost 100% are unstable fractures. The only contraindication for the putting traction is the occipito-cervical dissociation. So if you rule out the occipito-cervical dissociation, all other patients can be put on cervical traction, and they have to be managed surgically in case there is a cord injury.
Is it possible to approach C1 through the anterior approach for fixation?
Yeah, it's very difficult in those patients where there is a long neck, where in preoperative CT shows that the mandibular line is high up, where preoperative CT will tell us whether you will be able to reach C1 intraoperatively or not. If patient has a thick neck or obese patients, it's very difficult for us to reach the anteriorly C1.
Do you use steroids for any role of steroids for all these trauma injuries?
Steroids, most of the upper cervical spine injuries, they do not have any, they do not have cord injury, because they make the space capacious. So in case there is a cord injury, the guidelines remain the same as rest of the body.
Yeah. There's a question that how do you measure the 6.9 millimeter to decide it is instability or not? Can you explain again?
Yeah, in the CT, in the coronal sections where you see both the C1 and C2 joints, and in the CT itself, in the gantry, we can measure in millimeters. But nowadays, we follow, apart from that, the MRI is more sensitive for the transverse atlantal ligamental injury than this particular this one.
Yeah, the CT is an indirect evidence. MRI gives a direct evidence.
Yes, sir. Yes, sir.
Yeah. Dr. Erico has asked that what should be done if the patient has a red flag in
Posterior C1, C2 fixation.
yes. Any problem?
No, let me just connect the charger to my laptop, sir.
Okay. How much of weight you use for traction, and what is the ideal weight? As Dr. Vijay has some problem with the audio, in the meantime, I'll ask Professor Atul Goyal to give few comments. Professor Atul Goyal is online.
Yeah, Manas, can you hear me?
Yeah, I can hear you.
No,
can you give some management protocol, what you follow in upper cervical spine injuries?
See, upper cervical injuries can be quite complex and quite variable in their, site of injury, the extent of injury, the kind of dislocation, the kind of deformities that can happen, as has been very beautifully explained by Dr. Vijay. The issue is, what happens is when there is a fracture and significantly unstable, like hangman fracture, like Jefferson fracture, odontoid fracture, the most important thing that we have to identify is the region unstable? And more often than not, it is unstable, except for situation where it is odontoid tip fracture and here and there. Otherwise, in majority of instances, it is unstable, and stabilization is the treatment. I know many people like to do trans-cervical odontoid fixation like Dr. Vijay was showing, and anterior cervical fixation, plate and multi-level fixation. I do not like anterior cervical surgery at all for this situation, because one is that I am very familiar with the posterior techniques of fixation. And the second thing is, all the muscles of the spine are located posteriorly. Anteriorly, there is no muscle, except for longus colli, which is just a thin layer of muscle. Otherwise, there is no muscle anteriorly. So all the movements are actually regulated from behind. And if you have to stabilize, you have to first disconnect all the muscles which are going to make all the movements. And because all the movements are being regulated from behind, I like to do all my cases from behind. I know there are many people who like to do from front and multi-level fixation, as you have seen. But my feeling is, and I'm quite convinced with what I feel, is if you do any kind of fixation, the muscles of the posterior muscles of the cervical spine, which are like huge. The C2 spinous process muscle is a huge muscle. And if that muscle is not demolished, that movement that muscle will create has the potential to destabilize any kind of implant that is made from front. Despite saying that, I know many people, particularly orthopedic people, are very conversant and very happy with doing from front. But that is my point of view. And I was very happy to see a confident Vijay speaking about various things. And I am sure that he's doing a fantastic work.
So this, if the muscles are not detached from either the insertion or the origin, and then we work from the front, is it not that the muscles will act better post-operatively? The functions will be more preserved, because we're doing from posteriorly, we are detaching and then again attaching. So is it not more physiological?
Yes. let me just tell you what is the main biomechanics. See,
Yes.
when we stabilize, our implant goes from C2 to C3 or from C1 to C2 or C1 to C3. The aim, the success of that operation will be gauged by the complete stabilization. Means there will be no movement in that region. That will be success. Means it is fused. Fusion is the aim of surgery. You agree with that?
Yes.
Now that fusion, the problem is the muscles which are behind have so much power. You know when you open the C2 from behind, the muscles are like not exactly like, they are huge muscles, and they keep on giving traction to that area, and that fusion may not be allowed. So your fusion, there is a possibility of failure. That is what I'm saying of your implant.
Okay. There is a question from Dr. Musa. He's asked, when do you consider occipito-cervical fusion in cervical fractures? To Dr. Vijay. Dr. Vijay, you are with us? Dr. Vijay Sathi? Can you hear us?
Can you just repeat the question, sir?
Yeah. When do you consider occipito-cervical fusion in cervical fractures?
Generally, occipito-cervical fusion has to be avoided unless there is an occipito-cervical dissociation. Like, for example, if there is a fracture of occipital condyle leading to fixation, that's the only time when we can fuse from the to the occipital. Rest of the times, the C1, you can limit our fixation to the C1 itself. The only indication where you involve the occiput is the occipito-cervical dissociation or a comminuted fracture of the C1 mass, which is painful and also associated with the occipital condylar fracture, which is displaced too grossly.
Yeah. Dr. Harsh Shah has asked how much weight you use for traction. Can you explain depending on the level? The weight used for traction. Vijay, can you hear us?
Yeah, I can hear you. Basically, all upper cervicals, we start with the 2 kgs minimum weight and gradually increase by 2 kgs per day till it is reduced, or at 2 lbs per level. Maximum, most of the times we can reduce by within 6 kilograms of weight.
Yeah, basically it's at 2 kgs per body, and it should not be more than that. If it's the C3 is fractured, not more than 6 kgs.
Yes.
There's a question by Dr. Musa. Dr. Gupta has asked what screw you use for dense fracture. Can we use lag screws?
Yes, cannulated lag screw is the ideal one, where it can pull the distal fragment towards the base. Cannulated lag screw is the ideal one to be used for the odontoid fracture. Ultimately, the principle of surgery remains the same, that the transverse alignment has to be intact while putting an anterior odontoid screw.
Yeah, so the ideal screw is a cannulated lag screw, and if you do not have, then you can use a a normal screw lag. But the cannulated lag screw is the ideal screw for getting the apposition, so that the fusion is better.
Apposition. Yeah.
Satul Goyal, any other comments from your side, sir?
Regarding the issue of occipito-cervical fixation, when to include the occipital bone in the fixation construct, that was one question.
Yes.
Yeah, I was discussing the other day, the occipito-cervical, occipito-atlantal joint is the most stable joint of the body, most stable. You go to the cadaver and take an axe and try to break the occipito-atlantal joint, or take a very sharp knife and try to break the ligaments attached to the occipito-atlantal joint. It will be extremely difficult for you to open that joint because it is such a strong joint. And that joint is meant to hold the head throughout the human being's life. On the other hand, atlantoaxial joint is the most mobile joint of the body. Craniovertebral junction instability for me means atlantoaxial instability. Craniovertebral junction stabilization for me means atlantoaxial stabilization. I do not include occipital bone in the fixation construct in any case, unless and until it is a huge trauma where the occipito-atlantal disruption has occurred. But in my entire experience for so many years, I have never encountered that kind of trauma. Even in pediatric cases, syndromic cases, there can be multi-level, multi-segmental spinal instability, like in Morque's disease, in Down syndrome, in various other syndromes. But occipito-atlantal instability will be never seen. That is my experience in that. So inclusion of the occipital bone in the fixation construct, according to my understanding, is extremely rarely required, if at all.
Thank you, Professor Goel. There's another question for Dr. Vijay. What specific MR sequence you ask for looking at the integrity of the transverse atlantal ligament? Shall I repeat? We cannot hear you.
You have to unmute, Vijay.
Yeah. Question is which MR sequence? Usually
Yes.
the gradient echo 1 millimeter slices would be sufficient enough to look at the transverse atlantal ligament integrity. Gradient echo.
Okay. Thank you, Dr. Vijay. And then we are in right time for the